Hello everyone and welcome. Um, my name is Lisa Schwartz. I am the Arnold L. Johnson Chair in Healthcare Ethics at McMaster University. And together with the Global Health Network and the, I can't see it, Epidemic Ethics group, I'm very pleased to be able to welcome you here today to a session that we've titled Beyond Good Enough: How to Engage Communities with COVID-19 Research Quickly and Effectively. This is a panel presentation. I am your chair for today, but I'm very pleased to be able to, and I don't know, I'm going to stop sharing my screen for a moment. And wanted to be able to welcome you and the panelists sorry about that, to welcome the panelists, and I'll introduce them to you just now. Today we'll have Dr. John Marshall speaking. Dr. Marshall is the Professor of Surgery and Critical Care at the University of Toronto. He's the chair of the International Forum for Acute Care Trialists, is the past chair of the Canadian Critical Care Trials Group, and co-chair of the WHO Working Group on Clinical Characterization and Management, working on COVID-19. Also with us is Noni Mumba. She is the head of community engagement at the KEMRI-Wellcome Trust research program, and a long experienced field practitioner working with researchers now on COVID-19. Also with us is Phaikyeong Cheah, who is the head of bioethics and engagement with the Moru Tropical Health Network in Bangkok. Phaikyeong is the bioethicist and associate professor at the University of Oxford. And finally, Alun Davies, who has been working in the fields of science, education, and engagement with health research in Kenya for the past 26 years. And Alun's PhD drew on mixed methods, including participatory video, to evaluate engagement, and is working hard with groups now on COVID-19 research as well. This is a group effort. So I'm going to go back and share my slides with you, my screen with you again. It's a group effort of the WHO Task Force on Good Participatory Practices in Emerging Pathogen Research. This is a subgroup of the Social Sciences Working Group for the COVID-19 Research Roadmap, in collaboration with the Clinical Working Group and the Ethics Working Group at WHO. So we'd like to thank Dr. Nina Gobat, who's the lead of the Social Sciences Working Group, for supporting this, as well as Dr. Catherine Littler, who's with the WHO Secretariat, and all of the task force members, including Sasi Molyneux, Srin Murthy, Lena Moses, Elise Nouvet, Beatrice Tomei, Yolanda Bayugo, and Anna Berman. As researchers, I think we are all committed to being able to make our research as effective as possible. And as colleagues have recently put it, an essential component of doing this research is to maintain relations of trust between communities and research institutions. Research can't be done without that community support and trust. And as Dr. Catherine Hankins pointed out in 2016, as she developed the WHO document, Engaging with Communities, she pointed out that respectful engagement is the foundation of feasible, empowering, resilient, and successful research. And there is a substantial body of methodologies and tools, I guess, that can be used for engaging participatory approaches to making research successful. But because of COVID-19, obviously, we've had restrictive measures that have substantially diminished the existing resources and techniques. The rapid timelines, this new pathogen, no known interventions, layers of regional engagement, all of that, and on top of it, lockdown, which prevents us from going out and making the kinds of commitments and collaborations that we would normally rely on, have all made it virtually impossible, or certainly changed the terrain for doing good participatory work. Together with the task force, we've been working on some documents. You can find these at the WHO R&D blueprint, the link for which we could probably add to the toolbox on the side. Two of these, or sorry, the chat frame on the side. Two of these include the Good Participatory Practices for COVID-19 Clinical Trials Toolbox, which has a collection of resources that is growing and is changing as we go along, and the Working with Community Advisory Boards in COVID-19 guidance document. So right now I'd like to open the platform. There is opportunity for questions, and I encourage you to share these questions in the Q&A on the side. I will, at the end of the presentations, go over these and try to share some questions with the panelists. And we encourage you to ask as many as possible, because the importance here is that we have the opportunity to hear from all of you. So I'm going to pass this on now to Dr. Marshall, John Marshall, who will present for the next few minutes. Thank you very much.
Thank you very kindly, Lisa, and good morning, good day. Welcome to all of you who've joined the session today. So I'm really looking forward to today's session, in part because I'm a trialist and I really don't have the answers to the questions that Lisa posed at the outset of this particular session. But I do want to say, just provide kind of a high-level overview about community engagement in clinical research, scientific literacy, and why both are absolutely critical during this COVID-19 pandemic. It's certainly a platitude, really, to underline the fact that COVID-19 has fundamentally changed the world that we live in. We are walking around with masks, we are keeping our distance from each other, we are meeting by Zoom rather than in person, but we're also undertaking research at an absolutely unprecedented rate. I checked last night on the WHO's registry of clinical trials about the number of trials of COVID-19 that have been registered. And as of yesterday, there were 3,378 trials and observational studies of COVID-19 listed at that site. It speaks to an extraordinary ferment of interest in understanding this novel pandemic and trying to develop new ways to treat it. And it really speaks to the recognition and the embedding of research into the provision of clinical care for patients in the 21st century. There have been times when research was kind of a pastime for the idle, the well-to-do, the curious. Now it has become a critical component of our capacity to understand how to provide the very best care for patients. And so when a new disease such as COVID-19 suddenly appears on the horizon, research is critical. It's partly that we want to understand it. There's an inherent curiosity, I think, of all of us who've gone into medicine and who have engaged in research to understand the inner workings of biology and how things happen. But really at the heart of this, and why community participation is so critical to it, is a desire to change the current situation for the better. So I think it's important to recognize that science is not an ideology. One doesn't believe in science. Science simply is. It's a tool or a method that allows us to understand the world we live in. And it does that through two key processes. One, as much as possible, randomizing things that are happening so that any influence is the influence of something that is not random. And secondly, objectively comparing what is happening in one group of patients with a second group of patients. And so unfortunately in a pandemic, obviously the voices of the most powerful and the most influential gain traction that they don't necessarily have in biomedical research in peacetime. But I think it's critical to understand that this is not a question of what we believe or what our gut tells us. It's a question of what we can learn through the methods of science. And so from a community perspective, there are some critical questions here. Who sets the rules for how we understand what's going on, how we use science? Who sets the rules of science? Who asks the questions? How do we decide what the priorities are for study? Because my priorities as a clinician looking after critically ill patients may well be different from the priorities of someone who lives, for example, in Burundi and is worried about how to protect their children against a novel virus that they have little understanding of. So I think it's important to recognize that research is fundamentally an exercise in democracy. At its most basic scientific level, research gains its traction by the power of the majority. One does a study, such as this study that was reported recently for hydroxychloroquine for COVID-19, and one has a comparison between two groups, and you look to see which group does better. And the group that does better is the group that, because of the way the scientific question is structured, is more likely to do better in clinical practice. And therefore, just in the same way that in an election, the party that gets the majority of the votes, it sets the stage. In a clinical trial, the intervention or the group that gets that shows a better result is the one that we accept as being valid knowledge. Now, we're going to be discussing today some of the challenges to community participation in COVID-19 research, but I want to just highlight a few of these that I encounter as a trialist. First of all, who is the community? Increasingly, we're trying to engage the community and to engage patients in research, but I think it's fair to say that a lot of that at this stage is still at the level of individual patients, individual family members, and not a better biopsy of an entire community perspective on research. And I think it's important that the entire community have a voice in the same way that it's important that the entire community have a voice in the democratic process. How do they gain access? How do they find out about research? How do we connect the community with researchers? And what is their role having gained that access? Is it simply a token participant so that we can check that box on a grant application? Or, as is increasingly happening, can they actually shape the research question or even initiate the research in itself? And then critical to all of this is, how do we promote scientific literacy? How do we communicate to our planet that we have the tools to answer complex questions, and that having answered those complex questions, we can have the confidence that those answers are almost certainly the appropriate answers? This is inevitably a human process, and so it is filled with controversy, filled with a lot of noise. This is one of the latest controversies that just emerged over the weekend, based on a study that was done looking at social distancing in COVID-19 as to whether or not 1 meter distancing is equivalent to 2 meter distancing. It's a scientific question that can be answered, but it's a scientific question that's answered in a social context. And the fact that it's answered in social context inevitably leads to controversy and is a powerful argument in favor of all of us having a voice in that controversy and recognizing the strengths and the limitations of the tools we use. So just to summarize, unlike other health circumstances that we deal with, pandemics are unusual. They not only affect the individual patient who becomes ill, for example, with COVID-19, but they obviously affect that individual's entire community, their country, their continent, and as we know today, the entire world. And so the entire world has an interest and a need for a voice in thinking about how we move forward. Research acknowledges what we do not know. Research gives us the humility to say, I don't know the answer to that question. But it also provides us the tools that we need to find an answer to that question, recognizing that the answer is never fixed and immutable, but something that changes over time as more knowledge becomes available and as we respond with appropriately using the knowledge that we currently have. All of this requires that we work together effectively, and therefore it requires that those of us who are doing research engage as broadly as possible with the communities that our work is serving. So thank you for joining the session this morning, and with that I'm going to turn the floor back to Lisa.
Thanks very much, John. That was excellent, and I think it certainly sets the groundwork for proceeding from here on. We'll next go on to Noni Mumba. Noni, are you able to share your screen?
I don't have slides.
Excellent, but you have your screen. Welcome, thank you.
Okay, thank you very much, Lisa. Good morning, afternoon, good evening to you all. And I think this is just a very excellent opportunity to be able to discuss this very important subject. And thank you, John, for setting the tone of this discussion very, very well, and outlining some of the critical things that are affecting or can affect research, rapid research for COVID-19. A very critical one being voices of the powerful individuals, powerful media that are speaking to all of the populations related to this pandemic. So I'll give just a broad overview of how to plan and implement engagement for COVID-19 studies, and then my colleagues will probably have specific examples. And I think just moving on right away from John's presentation is that COVID-19 pandemic has come with a unique challenge, although it's not very unique because at the start of most pandemics, Ebola being an epidemic that we are continuously facing, HIV in the past, when they're beginning and people don't quite have enough information about them, there's bound to be, as we are seeing, a lot of misinformation, and as we've just said, from powerful voices, powerful individuals, and different groups of people speaking towards the pandemic and sharing what they think they know, giving rise perhaps to conspiracy theories, which then bring about fear, anger, anxiety amongst populations. Some of these conspiracy theories we've seen for COVID-19 are related to perhaps the origin, the perceived origin of the virus, conspiracy theories around big pharmaceutical companies and their agenda for perhaps enriching themselves. We've seen conspiracy theories around end times, and all of these make it very challenging to implement engagement, but also they point out to the importance of actually engaging communities and populations and stakeholders for COVID-19 research. I think another important thing which is contextual, which a researcher needs to understand in addition to what people are saying and what people are hearing about COVID-19, another really key thing that a researcher needs to keep in mind is, for instance, in our setting, low and middle income countries, and especially Africa, for example, there is now ongoing discourse, which is around the relationship between the global north and global south, politics around, who has power to do research, what is the place and what is the role of African scientists, what is the contribution of African scientists. And so a researcher coming in or a researcher wanting to do science or do a study for COVID-19 needs to be able to understand this context. And then this would be able to inform them what approaches would be needed for engagement and even where to start. So having understood the context, it's also important, and it's not a given that everybody understands what community engagement is. So what is community engagement, or how is it defined, and why is it so important? There are very many definitions for community engagement, and people define community engagement based on perhaps what they want to do with the engagement. But by and large, community engagement really refers to a process. It's not an event that happens, at one time point and then you move on to something else. It's a process where you bring on board or you collaborate with other individuals, other stakeholders, be they people who are in a geographic area or people with similar interests, to be able to discuss, to discuss priorities of health, priorities of research, and also to be able to address issues and concerns that those people have. So that is sort of like a brief definition of what engagement or community engagement is. And why is it important? As you will have seen, John has already alluded to this, is that community engagement is important because it is first and foremost a good thing to do. Research or science is a democracy, as you have seen on John's slides. And so people need to be able to be informed about what is happening or what is going to be happening to them or around them. And so it is a good thing to do. It's an essential part of research, and it can enhance ethical conduct of research. And it's a way of getting input into a study, input into study design, or even the process of implementing research. Engagement involves a two-way interaction. It is not one way, and it involves listening to people's views and being responsive, very important, to people's views, and demonstrating that you are incorporating the views that can be incorporated into research. So how can engagement be done quickly to support COVID research, which knowledge is urgently needed right now to address different aspects of this pandemic that we are facing. So how can this be done? How can engagement be done in a rapid way? I think first and foremost is to just say that it's not everybody who can engage, or it's not everybody who can do a community engagement, and a researcher shouldn't feel overwhelmed, like, what will I do? It's important to be able to identify stakeholders or partners or people that you can collaborate with. If you're going to a site or a location, you can look for locations or sites that already have good relations with communities, already have existing community engagement. But where there is none, then you need to do a prior mapping of the region where you're going to conduct your research and identify which are the local organizations that you can partner with there. You need to think about training for the people that you're going to work with, the engagement implementers. They would need to be trained, they would need to be supported, they would need funding. Community engagement requires funding. And so there's training, there's funding, and there's providing resources that teams can use to be able to engage the communities and other stakeholders. To be able to do rapid engagement, you need to have planned prior. So you don't wait until your study has been approved, and then that is the point when you're beginning to think, oh, actually, I need to engage a certain population. You have to start way before. In our experience, we begin thinking about community engagement right at the proposal development stage, or what we call a protocol development stage. And you begin to outline at that point, which are the stakeholders, how will I engage them, which methods and which tools am I going to use? And you do this in a collaborative way with the communities and even with other study staff who can input into developing the engagement plan. Once you've developed, you need to identify, of course, other stakeholders, important stakeholders that need early buy-in, like ministries of health and other regulatory institutions, perhaps even religious leaders. The people that you need buy-in from way early, you need to identify them, conduct a mapping, and then be able to meet them and be able to engage with them. in the times of COVID-19, social physical distancing, having face-to-face meetings is becoming even complex, and maybe it's not even possible. So it's good to begin to think about what technological tools can you use to do this engagement? What other methods of engagement other than face-to-face can be used? How are you going to use them? And even as you think about this, think about those people that may not have access to technology. How will they be brought on board? How will they be brought onto the table to discuss? And then you sort of like map out and have an outline of your activities, the tools that you're going to use, and then you begin to implement. And even as you implement activities, you need to put in place structures for continued feedback, because as I've said, engagement is a process, not an event. So it takes place throughout the entire life of the study. And so you need to have structures in place that will enable feedback for you to be able to learn, is this engagement approach working? What do we need to change? And you're getting feedback from the community, from research participants, feedback from other scientists. And at the end of the study, you need to be able to go back. People usually forget this, but you have to go back after you've gotten your research findings and then give the feedback of what you have found, because that is important in terms of relationship building and trust building. And you want to leave an area in a conducive way such that another researcher coming in will find that the population is not averse to research. Thank you very much. Back to you, Lisa.
Thank you. That was excellent, Noni. And as ever, you leave me thinking about so many different things. I'm delighted for that. I'll just remind everybody to please put questions and comments in the Q&A section, and we will be following up with them during the rest of the at the end of the presentation. So thank you again, Noni, and we pass on to Phaikyeong Cheah, who will explain some experiences with rapid engagement during COVID-19.
Right, can you see my screen?
Yes, we can.
Yes, we can.
Thank you. So, well, what I'm going to do is to talk about engagement around a specific project, and it's called the COP project. So I'm based in Bangkok with the University of Oxford collaboration here with the Mahidol University called the Moro Tropical Health Network. Okay, oops. No. So we're here in Bangkok, funded by the Wellcome Trust primarily, and we've been here for 40 years now, about 800 staff. Bangkok is a hub, but we conduct trials and research internationally. We do a lot of work on tropical medicine and infectious diseases with a focus on malaria, antimicrobial resistance, tuberculosis, maternal and child health, and now COVID. So the project I'm going to talk about today is called COP. COP is a study using chloroquine or N-hydroxychloroquine for prevention of COVID among healthcare workers. It is randomized and it is placebo controlled. Why are we doing this study? Because chloroquine and hydroxychloroquine are currently used extensively for prevention in many countries without evidence if they're beneficial or not. And this comprises over 20% of the world population. We are aiming to enroll about 40,000 participants from Asia, Europe, Latin America, and Africa. The 20,000 will receive drugs and 20,000 will receive placebo. What are our objectives for engagement? And I'm talking about the central theme here, engagement at the various sites. We won't talk about that tonight. So what is the objectives? The objectives are to obtain input for the development of the protocol and the procedures, to obtain input for communications materials, our website, our key messages and FAQs, to identify ethical and practical issues and other concerns that we may not see as researchers. So what are the key challenges? As you've heard, other than there's social distancing, but other than that is that this is a centralized protocol with standardized because it's a multi-center study. So it is largely standard with a small room for tweaking. The sites were not determined in advance when we developed the protocol. We had to put the protocol in for approval. So we didn't know all the sites that are going to take part yet, and we still don't know because we're just getting sites to come on board. And of course, there's a changing pandemic situation with new papers published every day, in fact. So these are the challenges. So what did we do? What we did was we organized engagement sessions with potential participants. And remember, potential participants in this particular study are healthcare workers, and some of them might be experts or perceived to be experts. So we did sessions in Bangkok, Chiang Rai, Vientiane, Oxford, and Ho Chi Minh City today. So 8 sessions have been done with 5 to 70 people per session. And each session took about 1 to 2 hours. So these are like workshop-y sessions. Participants were briefed on the planned study design and asked to answer these 2 questions. The first one is, would you like to take part in the study and why? And the second question is, what additional information would strengthen or make you change your mind or stick to your decision? Their responses were either written on sticky notes or spoken out verbally, and this was followed by open questions and answer session by the study team. The study team comprised, depending on where, of engagement specialists or study investigators at the site. In addition to engaging with potential participants, we engaged with the Bangkok Health Research Interest Group. This group is a public advisory group. It's based in Bangkok, established in August last year, and facilitated by moral engagement specialists. So they are not potential participants. They're rather members of the public, but they have an interest in health research. They do not represent any interest group, and they're independent of Moru or the KOPCOV team. They come from a diverse background and have a wide range of jobs and backgrounds. One of them works in the agricultural sector, another is a translator. We have 2 students from the 2 university students from political science, etc. We started, of course, with in-person meetings, and that was before the COVID pandemic, and now this group has gone virtual. So on 6th of May, we did a session with this group. We introduced the KOPCOV study and followed by some polling questions and open discussions. On the left of your slide, you can see some of the questions raised. One question was, if this is a double-blind study, how do we know who got medicine and who got placebo? One question, and then we answered, of course. And what was the criteria for you to decide Asian or European will take chloroquine or hydroxychloroquine? Well, the answer was simple, because chloroquine, so hydroxy and chloroquine are very similar drugs, but chloroquine, the chloroquine manufacturer was in Thailand, so sites in Asia would have chloroquine. Hydroxychloroquine manufacturer was based in, a company rather was based in the UK, so the sites in Europe would have a hydroxychloroquine. This is just logistics reason. And on the right of the screen is an example of a polling activity we did online. Have you heard of chloroquine and hydroxychloroquine? Yes, I've heard of it, but didn't know it was used for treatment or prevention of COVID. And no, I haven't heard of it before, or I'm not sure. Now the answers here surprised me because I thought it was in the news all the time. Everyone knew what the drugs were. So in addition to that, we asked a member of this group to be in the KOPCOV steering committee. So we get constant feedback from this group and a lay perspective on the trial throughout the lifetime of the project. So what we learned from engaging with these different groups of stakeholders. So unsurprisingly, we found that potential participants worry about side effects of chloroquine and hydroxychloroquine. Not surprising. There were mixed feelings about whether a prevention trial is necessary, because some of the places we went to, they had low numbers of cases. And there was some misunderstanding about the trial. For example, someone said, I would not participate because I would worry about my family. So I should stay away from the disease as far as possible. So maybe there was a misunderstanding about prevention trial. Maybe someone has heard about a challenge study. And some were unclear about the very basic of trial concepts like double blind and placebo, actually. So We've done these engagement activities, so that's up to that point, prior to 22nd of May. But on the 22nd of May, you might have heard, the Lancet published an observational study indicating that hospitalized patients with COVID-19 treated with hydroxychloroquine and chloroquine, the two drugs that we were using, were at greater risk of dying than patients not given the drugs. 22nd of May was one day after our study was launched in the UK, after a splash of press releases, media and all that. So the paper has been retracted since then by the three authors who are unable to complete an independent audit of the data, and they concluded that we can no longer vouch for the veracity of the primary data sources, and they retracted the paper. So that, even before the retraction, and even now, it has caused a flurry of activities. You may also heard that the Solidarity trial, about the Solidarity trial using hydroxychloroquine, there was a temporary pause in the hydroxychloroquine arm. It is now being restarted. And the COP-COV study was also paused because we were using hydroxychloroquine. So what did we do? There was a flurry of activities. We mapped out our stakeholders. So they were our participants, of course, because some people had already started taking the drugs, people in Thailand and the UK. We had to engage with ethics committees and regulatory authorities. There were internal stakeholders, our wider study team and collaborators, the wider scientific community, the public, and the media. What did we do? We contacted participants, most of the time by phone. We updated our website immediately. We had an internal newsletter, so we used that to communicate with our own staff and researchers. We had a position statement, press release, we updated information sheets, and it's still ongoing. Everyone in the team is involved in engagement, researchers, investigators, community engagement team, comms team, everyone was involved. We're hoping to prepare for a restart and the next flurry of engagement activities. So the story hasn't ended, but I'm ending my presentation now. If you have any questions, I'll be happy to take them later. Well, thank you very much.
Thank you for such an, thanks Phaikyeong. That was a very original presentation, and glad to see some exciting ideas coming out as some of the questions in the chat have been asking about new interventions. So this is a great start. We'll now pass it on to Alun Davies to share us some more. Thanks.
Hi, good afternoon. Okay, just give me a minute. Okay, so I'm going to try and, in a way, respond to Phaikyeong's mention of her findings, where there's a kind of mixed understanding of trials, to try and respond to John's fourth goal for this session, which was highlighting the need for promoting research literacy, and also Noni's suggestion that in these limiting times of COVID, that there's possibly a need for technological tools. I'm going to talk about a modifiable tool which can be used to kind of help explain COVID-19 trials. I should point out at this stage that it is a tool, and there's a need for many, many tools in this area. It's by no means a silver bullet, but it can perhaps be a bit helpful. So a large part of my work has involved establishing a school's engagement program for engaging young people through primary science clubs, through secondary school lab tours, interactions with scientists and young persons advisory groups, and pre-university attachments and university engagement, university student engagement. So the ideas I'm going to discuss with you today actually came from interactive sessions and materials we developed to strengthen school students' understanding of malaria clinical trials, some of our colleagues here felt that some of these tools could be more applicable specifically to and modified to be used for COVID-19 trials. So why do we need tools to support engagement with clinical trials? Well, it would be challenging to conduct ethically and practically to conduct trials without the support of community and health stakeholders. Importantly, trials can be strengthened through incorporating the informed views of stakeholders into the way in which trials are implemented. But facilitating this requires a good understanding, stakeholder understanding of how trials work. So this tool I'm going to show you today was developed to support stakeholder engagement so that discussions could be had about the best ways of implementing trials. Secondly, therapeutic misconceptions or failure to distinguish between research and treatment is common in Kenya, as it is throughout the world, and therapeutic misconceptions pose a threat to informed consent. So obviously engaging stakeholders and community and health stakeholders is important to support practical and ethical aspects of trial implementation, and also informed input from stakeholders is important to implement trials. There's also a concept of therapeutic misconceptions, which is common in Kenya, or has been described in Kenya, and also common in other parts of the world, and that can undermine the informed consent process. You can imagine that an overestimation of the clinical benefit of a trial product, or an understanding that a placebo could offer protection, could place a participant at increased risk of risk behavior, like, for example, hand washing or social distancing. So what are the tools? Well, basically, they're a set of PowerPoint slides, which are kind of widely applicable for a range of trials and they describe various aspects of a trial, from vaccine development to ethical review.
Gosh.
Hello again?
Yeah, we lost
Hi.
you.
Can you hear me?
Back.
Okay. So I chose PowerPoint because it's very versatile. In that PowerPoints are easily modifiable, local scripts can be added into it, and the files can be exported to MP4 video format. This is a prototype tool developed basically from 10 years of use with school students, and modified, but with inputs from the PIs in Kenya and from experienced engagement staff. So this next sequence was developed to describe one way of making a vaccine. See if I can make this work without muting myself. So genetic material is taken from a COVID-19 virus and incorporated into the genetic material of a modified vector. And then when this is introduced as a vaccine, the anticipation is that this vaccine will stimulate the body's immunity and give protection against COVID-19. So this next sequence illustrates how randomization is done, provides a visualization of how trial outcomes are compared between intervention and placebo arms. So participants are given either a test vaccine or the placebo, and this is decided randomly or by chance, a bit like flipping a coin. The participants don't really know whether they've been given the test vaccine or whether they've been given a placebo, and this is to make sure that the behavior is not influenced by the type of vaccine given to them. So over the next 12 months, the participants will be monitored and regularly tested. And as new infections inevitably occur from exposure to infected people in the community, researchers are able to see whether the trial vaccine gives better protection than placebo. So this sequence highlights that throughout the trial, participants are monitored for their health, their safety, for immune response and for protection, and that it emphasizes that throughout the trial, participants should adhere to public health advice on social distancing, hand washing, and that kind of thing. So what the next step is, the slides can then be, a narration can be added to them in any language, and then it can be exported into MP4. And this clip gives you an example of what it looks like with a voice added to it. Oh dear, it's not working. Is it working? Okay, perhaps this is not illustrating how it sounds with a voice. Okay, anyway, let me just talk over it.
A tremendous amount of lab work is needed to develop a vaccine, and this can take many years. From the initial lab work, trial vaccines are first tested on animals, and if safe, they proceed through different stages of clinical trials with people. Initially, trials with relatively small numbers of volunteers are done to see how the body's defense reacts to the vaccine and to confirm the vaccine's safety. Then, trials are done with larger numbers of volunteers to see whether they give protection against disease. When there is strong, carefully reviewed evidence of protection, regulatory bodies give permission for the vaccines to be rolled out to larger populations, but the vaccines are still monitored. The whole process of developing and testing a vaccine can take many years.
Okay, so these slides are available if anybody wants to use them to be modified. They'll be available through the MESH site. There's a MESH page. The work, and that's a tool. Thank you.
Super. Thank you so much, Alun. Great to have some very practical hands-on notions of how this works out. I think we can end sharing the screen and bring up the panel again. First, thanks very much for excellent presentations, series of presentations. And John will ask you to turn your camera back on. Great. So questions are coming in, including a comment on the brilliant animation, Alun. Thanks very much. And I guess I can go to I'll do a sort of summary of some of the questions as they've come along. One of the first questions that John rose as well in your introduction is about identifying a community, and in particular, how do you identify the representative of a community? So I will open that up to the entire panel for response. I wonder.
I think I can start.
There are obviously
yes.
many communities, so I'm listening to the rest of you.
I think I can start and identifying a community who represents a community or which stakeholders need to be engaged is not a very easy task, and it requires careful thinking, careful planning, and that's why the more importance why somebody needs to really start early. When you get into a population, you would need to go to relevant offices and find out. For instance, in our case here, we have social services offices that register community organizations. the Ministry of Health has, there's a sort of like a hierarchy of leadership in the community, right from location level to village level. And there are different people that you can reach out to who then would be able to advise you how best to go about identifying community representatives, or who to represent a community, or how to access the population. So there's no clear-cut answer. It depends on the location where you are, the structures that are in that place that you need to understand and be able to access those structures, and then be able to access the populations through that.
Very helpful, thank you. Does anybody else have anything to add to that? I think that was a great response, very thorough. And I think it also indicates why it's so important to work with a professional community engagement group or individual who has the connections usually already established before going into a different community. Another question that we've had from a couple of people is, do you have any examples of any good new practices that you have used or that you have seen others use? Now, we've had some examples from Phaikyeong in particular and from Alun and Noni, but do you have anything that you'd like to share in addition? Nothing else new than this.
Sorry. Yeah. So I mean, we have diverse populations in our context here. We have populations that have access to technology. So those ones we have been reaching out to them using technology, and we have such as Zoom meetings and so on. We are still, however, reaching some of our stakeholders with still face-to-face. I've been to Department of Health meetings that are still face-to-face. They have meetings in the morning, you go into that meeting, you present your study, and you take your views with social distancing. But we are also piloting using phone calls. Today is what, Monday? On Friday, we had a very fast telephone meeting with our community representatives. These are typical community members that not necessarily have access to Twitter. So we literally just used Skype for Business, and then we added them through their mobile phones. Perhaps that may be something that we'll continue using, maybe not. So those are some of the things we are doing.
Super, thank you. John?
I could maybe add to that. We currently are doing an international trial for COVID-19 that's a platform trial. It involves multiple different interventions. There are upwards of 10 different interventions at this stage that patients can be potentially randomized to. One of the challenges of this is that it's meant that from an REB perspective, our informed consent form is now in excess of 20 pages. So we have been working with a group of ICU survivors and their families in a project to sort of figure out how can we refine the process of informed consent so that it truly is educational for the people who are giving their consent to participate in a trial and not absolutely overwhelming and impossible to comprehend. So I think there are a lot of opportunities. Another colleague of mine has done some work with a group of patients who are ICU survivors on a clinical trial, and as a result of their input, actually changed the primary endpoint of the trial because it became apparent that the question that was being asked was in the right domain of interest, but it wasn't the particular focus that a patient might have if they were in that trial.
Excellent. Well, all wonderful interventions. We'll look forward to seeing the outcomes of some of those. I don't know if the others had a response to that as well. That's quite a lot to pick in.
Add a little bit about our Bangkok Health Research Interest Group that has gone virtual. So this week we would be having our 4th virtual meeting, and so we're using Microsoft Teams as a platform. So the chat function is quite good. And then we also supplemented with it's a virtual post-it session. And people can post things on the virtual wall, and it is worked out quite well. So obviously you have to have internet access, but it also encouraged people who normally didn't talk in the face-to-face meeting to give us so much input, and we were very, very pleased about that. Yeah.
Excellent. And this brings us to the next question that, again, a couple of people have asked, which is what happens when you can't access people through technology? How do we keep from skewing the population engagement base to only those who have access to online techniques?
I can answer and then others can add. So I think what we are finding is even though there is social distancing, there's quite a lot of community work that is still ongoing, and there's community organizations that are continuing to work. And so true that if one bases their engagement just on technology, then they leave out these other perhaps disadvantaged people. And so thinking about what, as I said, structures like community health workers that are continuing to go about their community health work in the population, how can you bring those on board and work with them to be able to engage the populations that you want to reach? What other local, what we call here in Kenya, self-help groups, because they are still going about their work. Which ones are out there, and which ones of those can you bring on board and be able to work with? So there is different ways of still continuing on with the typical engagement, but maintaining the preventive measures so as to ensure that people are safe.
Thank you. A couple of questions, and I'm torn between which ones to ask. Probably the first one that came up was about areas of protracted conflict and how to engage communities effectively in settings where there's such high risk and uncertainty and insecurity.
I'm happy to have a first go at this question. I think researchers have an obligation to look very carefully at the context in which trials are being done, first of all, and to make a decision helped by ethics review committee of whether participating in that research puts participants at more risk than normal behavior. Then there's an obligation not to conduct that research in that area, or at least without very, very careful public and community engagement first. I mean, there's also, I think that's the main one of the most important considerations.
So it actually raises the stakes and makes it even more significant than it would have been otherwise.
Yeah.
Anyone else care to add to that?
I mean, I don't have personal experience with it, but I can comment on during the Ebola outbreak in the Congo, in the DRC, there was some very, very good research that was done under those circumstances. So it certainly can be done, and I do think that it's critical. Research does occur in a context, and conflict is part of that context for all of us.
That's absolutely right. Looking for some others. And I guess it also raises the question about context and contextualizing. So we've had some questions and comments about the best ways to contextualize research, but because this is a pandemic and there's global engagement taking place, is there anything special or any considerations that you would add that would need to be done? And considering that we're at the hour, and I wanted to ask one last question, so anything in particular? I think Alun's videos contribute enormously to that possibility, and especially because your voiceovers are different. And I think one more question had come up about tailoring the language for different audiences at different times. So somebody was asking about, taking out the heavy scientific language and the importance of that. I think I'm not even going to have, sorry.
Yeah, no, I just think, it's important to try and, as much as possible, to convey this science across in as many different levels as possible. Because I think that there is a real danger that if you...
Oh, we lost you again. No sound.
I think...
Okay.
Sorry. I think there's a real danger that if you oversimplify the science, that you do people an injustice, and that you kind of you are potentially at risk of patronizing people. So it's a real kind of real challenge to get the balance right, and potentially the need to explain things at a range of different levels using a different visuals and different metaphors to describe things. I think it's a real challenge.
And I think it's usually helpful when the researcher is aware of people who may not understand scientific terms. I was in a meeting on Friday where two of our scientists were presenting a study, and the county health minister is a lay person. And one of the researchers was trying to break down. So they would still use the scientific term as Alan is saying, but they would also break it down to ensure that the lay people in the room are also able to understand. So when they said, for example, a DSMB is going to look at the safety, they would explain what is a DSMB. We are going to use a placebo. One will be given a placebo, another one will be given hydroxychloroquine. They would break down what does a placebo mean. So it's understanding your audience, and then trying to ensure that everybody is with you, even as you share your work.
Excellent. Thank you all so much. This is tremendous. I think it's given us a lot to think about too on the task force, and some possibilities of new directions for us to go in. So thank you again for the work that you're doing, and many thanks to the support to the Global Health Network for this.